Good evening, everyone. Before I start, I would like to thank Team GastroCare and Dr. Sanjay Kumar sir for giving me this opportunity. This is one of the most important topics for everyone, and particularly surgeons who are contemplating a surgery on an operable biliary cancer. So, just to have an overview, we have various different kinds of tumors and locations of tumors around the biliary tract which will cause surgical obstructive jaundice. So my main concentration will be on perihilar and the distal cholangiocarcinomas. So why should we deal with this? This is the first question that we all should ask ourselves. So from the very beginning, as physicians, we all know that bilirubin will have a lot of effect on other organs, particularly the cardiovascular, renal, immune system, and the hepatobiliary itself, like the liver cell failure leading to coagulation deficits, nutrition problems, and biliary infection and pruritus. So all these things will have a negative influence on surgery and surgical outcomes. So this is what is actually feared of, and what is the most fearful factor for us is whether this will increase the morbidity and mortality of the patients. So coming to the data, we have to see whether it is real in practice. So this is the data for perihilar carcinomas, where the data has shown that a primary biliary drainage doesn't actually change the mortality, and the morbidity is almost similar or higher in drained people and not drained people. The main reason could be one thing is the amount of morbidity and mortality that happens when primary biliary drainage is not done compared to the amount of morbidity and mortality that happens with the primary biliary drainage. It balances itself, so we don't actually see much difference between a primary biliary drainage and no primary biliary drainage. So the same thing happened even with distal cholangiocarcinomas also. This is the data that has initially. Then then when we closely observe the data, what we have, when we closely observe the data, what we have realized is there are a certain group of patients in whom the primary biliary drainage might actually help. So, so the indications will be, this topic has already been discussed in the last session when we are discussing about GB malignancy, but again we go a little bit in depth. यहाँ पर आ रहे हैं. The first and foremost indication will be the presence of urgent indication for biliary drainage, which is actually an acute cholangitis. As already discussed previously, intense pruritus and very high bilirubins are relative indications for biliary drainage. So there is data from Van der Gogh, that is around in 2010 or something, where he has shown that very high bilirubin levels can cause increased morbidity. So he advocated doing biliary drainage in these patients after a certain hemoglobin level, and this has been adapted by ERAS protocols also. So they say that less than 15 milligrams of bilirubin, total bilirubin, is desirable when it is distal cholangiocarcinoma. But again, a lot of data has come from 2012 till now, and most of us surgeons, including me, we don't follow those things. We like to operate when we don't have any definitive indications. We like to operate even with high bilirubin levels. Then comes the functional status of the patient. The functional status, that is nutritional status, which is assessed by albumin less than 3.5 milligram per deciliter. It increases the morbidity. And coagulopathy, hepatic dysfunction, renal failure, and cardiac failure, they are all relative indications. Coagulopathy is something that is very important, which can be managed with vitamin K injections as such. And when we have planned for a neoadjuvant chemotherapy, it's better to do biliary drainage because it will have a amplified effect on liver dysfunction. And particularly when it comes to hilar cholangiocarcinomas, because most of the hilar cholangiocarcinomas, almost 80% of them will need a hepatectomy when we are doing surgeries. And most of these hepatectomies are right-sided rather than left-sided. So the FLR is going to be very less in these patients. So we have, in most of these patients, when they are operable with the little numbers, whatever we get, when they are operable, it's better to do a biliary drainage to improve the functional liver residue of these patients. Then when the anticipated time for surgery is higher because of the volume at the institute or because we need more maneuvering procedures for increasing the FLR, or when we have planned for a neoadjuvant therapy, then we do a primary biliary drainage in these patients. So how do we assess? So before going to any drainage procedure, it's very important to have a roadmap of what we are going to do and how we are going to do, and what method we are going to do. So CT is the best method as of now. It gives us, it helps us in classifying these perihilar tumors particularly. It helps us in staging and planning the surgical resection. And it also helps in planning our preoperative maneuvers. Preoperative maneuvers to increase FLR are mainly primary biliary drainage, and portal vein embolization, neoadjuvant therapy, liver transplantation, and the ALPS procedure. But in perihilar lesions, adding an MRI with an MRCP will have an added advantage, because MRI and MRCP are better in assessing the intraductal and intrahepatic spread of the tumors. So we always add an MRI and MRCP in perihilar tumors. So coming to that, the main aim of the surgery is to get a negative margin and to get an adequate FLR. So based on that, we will choose the procedure in these patients. So how do we do it? We have multiple methods of doing a biliary drainage. So, but the most conventional one was the surgery, because since the time we started doing surgeries, we have multiple ways of doing it. We do a cholecystogastric, cholecystoduodenal, choroidocoduodenal, hepatico-jejunal, hepatico-duodenal. So we have multiple methods of doing these surgeries, drainages. And then in 1960s, percutaneous transhepatic biliary drainage was introduced, and it has changed the way we deal with this biliary drainage. Then in early 70s and late 70s, different techniques of endobiliary drainage have been introduced, and they all have different roles. So the ENBD is one of the first endobiliary drainage methods that was introduced, probably in the early 70s. Then came the endoscopic retrograde biliary drainage in the late 70s and early 80s. Then we have other methods in the last 2 decades, which are ultrasound guided procedures. In there is a significant development in endoscopic retrograde biliary drainage. There have been plastic stents, then we have metallic stents, self-expanding metallic stents, then we have fully covered, uncovered stents. There are multiple methods have developed since then. So I'll try to show historically in the same path. I'll try to show differences between surgical drainage and biliary drainage through endoscopic methods and percutaneous drainage. So the overall, if you look at, I'm not going into detail with every study that has been done. I'll give the gist of all the studies. So surgery is only better when there is because in decreasing the recurrent biliary obstruction in compared to any biliary drainage technique, minimal biliary drainage technique. Otherwise, surgery has performed very poorly because the number of complications are high, 30-day mortality is high, then we have a poor quality of life, duration of surgery, stay in the hospital is high, financial burden is high. In every way, surgery has performed poorly. Its current limited role is in inoperable, when the tumor is inoperable, when we have done a laparotomy for a expected operable case, or when there is a failed or complicated biliary drainage method. Otherwise, surgery doesn't have much role as of now. Then comparing PTBD with endoscopic biliary drainages, points in favor of PTBD is, like already discussed, it has higher technical success rate compared to endoscopic techniques, and fewer complication rates, and less crossover treatment, because if PTBD fails, we don't go back to endobiliary drainage, but if endobiliary drainage fails, we can always go back to PTBD. So that crossover is much lesser in PTBD patients compared to EBD. So points in favor of endoscopic biliary drainage are adverse events are less, shorter hospitalization. Most of the times it is done as a daycare, so the cost is decreased, and the survival of these patients is much higher because bile is getting drained into the natural GI tract and all the nutrition is maintained. So, and there is less peritoneal and liver recurrence in these patients because we are not going transhepatically, or we are not penetrating through the peritoneal linings, which happens in PTBD. So, so the disadvantage of PTBD is higher risk of vascular injury and bleeding, and then higher risk of cancer dissemination, and biliary peritonitis if there is a leak in the peritubal area, and it is contraindicated in coagulopathy. Even in endoscopically, it's a bit of contraindication, but we can still manage with techniques endoscopically. So drainage related complications are similar between PTBD and EBD, and therapeutic success after 1 week is similar between PTBD and EBD. So current indications of PTBD are very limited. We don't do much of PTBD these days because endoscopic drainage techniques have evolved so much, which I will discuss shortly in the end. Its current indication is when the papilla is not accessible because of narrowing at the gastric outlet obstruction, or because of alternate anatomy post surgery. When skilled endoscopist is not available in your center or nearby areas, or when there is a failed endobiliary drainage attempts. So those are the limited indications as of now. And coming to EBD, we have endonasal biliary drainage and endoscopic retrograde biliary drainage. So endoscopic nasal biliary drainage is introduced in 1960s by the Japanese, and even today they're successfully following it, and I think they're doing ENBD in Asia, AIG routinely. So the advantages of ENBD is endoscopic sphincterotomy is not routinely required in most of these patients, and the duration of doing the procedure is much shorter, and cholangitis is significantly decreased because there is no reflux of enteric contacts back into the biliary tract, and surgical site infections are less because all the infection or everything is drained back outside, and stent dysfunction is less, and it is easy to monitor. Whereas ERBD is tolerance is better, efficient drainage is possible, and lesser stent dysfunction in these patients. So coming to SEMS and plastic stents because of shorter duration, they don't do well. It's better to put a SEMS. SEMS is the current recommendation for all kinds of endobiliary drainage procedures, particularly in malignancies. And there is no significant difference in cost because plastic stents have to be done repeatedly, whereas SEMS, it lasts longer, and single procedure might be useful in most of these patients. So again, fully covered SEMS is preferred compared to uncovered SEMS because of longer patency. And it's quick to start a neoadjuvant therapy and easily removable at surgery and low risk of tumor growth. So these are the conclusions. Routine primary biliary drainage is not recommended, and it is done in very selective patients. And if FLR is more than 50%, there is no need of any kind of drainage for liver resections, and if it is less than 50%, we aim to drain the FLR area, and we prefer keeping bilirubin less than 2 milligrams per deciliter when we are planning a hepatectomy, major hepatectomy, and total bilirubin less than 15 by some, but we don't follow. We have done even 30 bilirubin also, and EBD is the preferred method in draining techniques. Thank you.
Thank you, Dr. Pavan, for an excellent lecture. Just to set the ball rolling, just wanted to ask you one question. Everybody wants stents, metallic stent to be placed for palliative biliary drainage. But a patient who have got bismuth type 2 block, usually what is recommended, you put a short metallic stent in these patients, not longer ones. So in a patient who has got bismuth type 2 block, if you want to put a metallic stent for biliary drainage, how about basically ease of surgery after taking out stent from basically right hepatic duct or something like that?
Sir, that is the reason why we prefer using fully covered stents. Fully covered stents are relatively better in pulling them out compared to an uncovered stents. It's not easy. It makes our life
again,
difficult.
with fully covered, migration is higher.
Correct.
You don't put plastic because chances of cholangitis are higher. But with fully covered, migration is higher. Chances of blockage of cystic duct, pancreatic duct, and subsequent pancreatitis or cholecystitis is higher. So basically, there's no safe haven. I think
there is no safe haven.
Same thing. Actually, I wanted to ask. In what we are talking about is an operable patient.
Yes, sir.
And earlier we all used to put plastic stents, and results were not bad. So now, of course, we know that metallic stents lead to dissolution of, reduction of bilirubin faster, and patients can be taken up for surgery. Okay. But a lot of surgeons say that with a metallic stent in, if they operate after 1 month or so, then surgery is more difficult. They have more inflammation around CBD, and it becomes difficult. So, would you still recommend a metallic stent?
Sir, as a surgeon, given a choice, I would prefer a plastic stent because it makes my life easier. But in terms of data, and yes, it's a bit difficult, but we can still maneuver it. We can get over that stent area with a little bit difficulty, but we can still do that. But as long as it is doing more benefit to the patient, I think we have to accept that bit of discomfort, and we have to go ahead with that.
Dr. Pavan, are you aware of any trial comparing multiple plastic stents, say putting 2, 3, certainly decreases chances of cholangitis rather than single metallic? Dr. Mohan, are you aware of any such trial?
Single metal stent versus multiple plastic stents.
For palliative, basically, in patient who have got operable biliary malignancy, you have to put stent for short period just to reduce bilirubin, cholangitis, and all those things. Any study comparing multiple plastic stent and versus metallic stent in these
Okay,
group?
so the question is pre-operative biliary drainage, multiple plastic stents. So multiple plastic stents has been devised for benign biliary stricture, where we call the patient every 3 monthly to drain it. But if you want to plate at one time, multiple plastic
say 2 or basically, for surgeon it is always a nightmare taking out metallic stent from CBD. However, basically studies they might be there, but if you ask any surgeon, for them putting metallic stent and then operating upon such patient is a nightmare.
I think presently standard of care is fully covered metal stent for lower CBD, and if possible NBT for the hilar. This is the standard of care presently.
But NBD is not widely practiced. That's the issue for us.
Studies have shown, and people are now moving from stent to NBT in majority.
So hilar, we would prefer getting a plastic stent rather than a metallic stent. Whereas if you can do NBD, I think that will be more useful for us.
How frequently are you doing endoscopic drainage in hilar carcinoma? I mean, the traditional teaching said, better to put a do a PTC or PTBD, do internalize, you can internalize the stricture site or the tumor site also. If the issue is bile is going out, it's not coming directly to GI tract. So there's a obvious difference between putting the stent from below in the hilar cholangiocarcinoma and then putting the stent or PTBD from above. There are more chances of cholangitis and infective complications by doing intervention from below. And say gallbladder inoperable or potentially operable, or in cholangiocarcinoma bismuth type 2, more than 2, 3A, 3B. So how frequently are you doing? I mean, I heard you are doing endoscopy yourself, ERCP yourself. So how frequently are you doing these procedures in your patients?
I don't do ERCPs and endoscopies, sir. I'm a surgeon. But my team, what they do is they prefer doing a endobiliary stenting only with a plastic stent when it comes to ILR. The issue with, not exactly issue, when we do a nasobiliary drainage into the duct where we want to drain the FLR, you might actually develop a cholangitis in the other lobe where we want to resect. So that is one place where we might have to take help of the interventional radiologist to put a PDBD in the other lobe. Because once you put an NBD, I think it's very difficult to introduce another NBD into the other duct. Whereas with plastic stents, it's easy. ERCP, when you do an ERCP, if you put into left, you can again put into right. That becomes much easier.
One comment, I'm an interventional radiologist from Institute of Liver and Biliary Sciences. So it may be an institutional practice how it differs, like a ERCP versus percutaneous drainage. But in our center, mostly it is the surgeon's preference is a percutaneous drainage, where we put a percutaneous drain and we try to internalize it, cap it. If the patient tolerates it well and good, again it can be changed into ERCP stenting. If he does not tolerate and he has elevated counts or going into cholangitis, then we pull it just above the ampulla, across the stricture, keep the patient on external drainage, and that brings down the bilirubin much faster, and probably the patient gets to surgery much easier unless until malnourished.
Agreed. And with that, I will just conclude the session. Sorry, Saurabh, you can ask the question, during the break time. So conclude the session with that. Thank you so much.
Thank you.